Thank you, everyone. Our next session is on hemodynamic monitoring. What is the evidence in children? I would like to request Dr. Priyavartini, our speaker. Ma'am is a pediatric intensivist at Apollo Hospitals, Chennai. And I would like to request Professor Shopna Chakraborty, our chairpersons for the session. Ma'am is the former HOD of the Department of Pediatrics, JNM Medical College, Kollani, and Medical College and Hospital, Kolkata. Please, Madam.
Hello. A very good afternoon to I must thank the organizers of this conference, and most of them and many of them are my students, including the Shatarupa, who has introduced me already, and she has done my work. She has introduced the speaker also. So let us start. Let Dr. Priyavartini, you start. You will speak on hemodynamic monitoring. This is a very important practical aspect of this critical care, though all aspects of critical care are definitely practical oriented. And when we were working on intensive care in that time, and now it has been greatly advanced. So I would like also to learn from you, and including the audience would be benefited definitely.
Thank you, ma'am. Thank you for the kind introduction. Very good afternoon, one and all, and I would like to thank the organizers for giving me this opportunity. Before I start, I would like to know, how do you think we all do hemodynamic monitoring in children? So, what is your favorite way of monitoring? Just quickly, before we move on. Anybody? Excellent, excellent. So, anything else? So, quite a bit of stuff here said. Anything else? ABG, very good. Anything else? Yeah, ultrasound. So anybody uses invasive blood pressures monitoring? Central venous pressure monitoring? Yeah. Which do you think is more important? Arterial blood pressure or central venous pressure? Okay. So anybody else? Anyone else thinks otherwise?
Mixed venous and lactate.
Okay. No, between arterial and blood pressure and CVP. Of course, sir, definitely. So like sir said, clinical monitoring is first and foremost. Out of the other two which I asked, invasive blood pressure and CVP, I would say CVP is more important. It's like the woman of the house, okay? They may be subtle, they may be soft looking, but they are the anchor, okay? So let's see how it goes. I will explain that later in my presentation. Okay, so it's a very short topic. It's a very broad topic in a short time. Okay, so I'll touch upon things. So basically shock is, we all know shock. It is maldistribution of blood flow, and it is very common, and hemodynamic monitoring can provide useful insights, but we have paucity of data in children, okay? And the ideal way of hemodynamic monitoring should estimate the severity and also identify the underlying pathophysiological mechanism so that you can address that accordingly. And we have invasive methods like invasive arterial blood pressure, CVP, and we also have non-invasive methods like ultrasound. So I'm going to touch upon a few things like the clinical signs which the audience already mentioned about: invasive arterial blood pressure, CVP, point of care ultrasound, lactates, central venous saturations, a little bit on the fluid responsiveness, which has become kind of a little obsolete now, NARS, VA, CO2 gap, mixed venous saturations, and cardiac output. Right, so clinical signs we all know: rate, blood pressure, respiratory rate, mental status, urine output, peripheral perfusion. They are all age dependent, and they can be altered by many things such as pain, anxiety, and temperature. So there are a lot of problems, we know that, okay? So, and there is not much of clinical correlation all the time in critically ill between clinical assessment and invasive hemodynamic parameters. So we had recently a patient with coarctation of aorta. The resident said, completely bang normal child. When I assessed, child looked clinically reasonably well perfused, alert, and look at the blood pressure. look at the blood gas. The lactate is close to 9, okay? So it's not always we can get away with just clinical assessment, though that's the first and foremost. We have to put everything together. So we do understand we need more information. So the recent ESPNIC guidelines in 2020, which was released on hemodynamic monitoring in children specifically, said no single clinical parameter is enough. And also you need to look at trends. You have to reassess periodically, and you do not titrate hemodynamic therapy or fluid boluses solely based upon clinical signs or a reduced urine output alone in unstable patient. Like you can do that in the initial resuscitation phase, but you should not go on doing that in the subsequent phases if things don't add up. Next comes your blood pressure. So blood pressure can be measured non-invasively or invasively. See, there can be discrepancies between invasive blood pressure and non-invasive blood pressure, especially in obese and edematous children. You can see here the blood pressure, this is the NIBP value, and this is the invasive arterial blood pressure. There's remarkable difference, okay? So if you think some patient is going to have rapid hemodynamic changes, then please do use intra-arterial blood pressure measurement. And if your shock is not responsive to initial fluid therapy or requires vasopressor treatment, or in patients with even hypertensive emergencies, not just in shock, you may need to use an invasive arterial blood pressure. And again, do not use blood pressure as the only therapeutic target. There may be patients with cardiac failure with very, very low blood pressures, but they are otherwise well perfusing, warm, with normal mental status, normal urine output. So we don't have to chase blood pressure as the only thing, provided everything else is normal. A few things on invasive blood pressure monitoring. So when you talk about blood pressure, which component of blood pressure you think is important? Which component? When we say blood pressure, it's good. Which component? Systolic. Most often we all, talk about systolic blood pressures, or, some of the critical care people talk about MAP, okay? But every component is important, okay? That's what this recent article says. And systolic blood pressure, we all know that's the major hemodynamic target. And especially if a child is bleeding, look at the systolic blood pressure, because that's the peak pressure with which somebody bleeds. So control the peak systolic blood pressure there. I'm not too bothered about the MAP or the diastolic blood pressure. So, okay, that's normal. And diastolic blood pressure. So there is a word called diastolic hypotension. Look at that as well, okay? Because that may be due to many reasons like sepsis, post-cardiopulmonary bypass, or excessive use of vasodilators. It has got very profound implications. Why? Why is it so? Why is diastolic blood pressure very important? Because the coronaries are perfused during diastole mainly, okay? So coronary perfusion is very, very important, so that is one of the main reasons. Okay, so you can see this is a child who has got a blood pressure of 72/23. Look at the diastole is pretty low. Okay, this child has received milrinone, levosimendan, diuretics, enalapril, now has decreased urine output. So this child probably needs some pressors to bump up the blood pressure. Okay, so this can result in trouble. Okay, so that's not a normal number, 23 of diastole. So that needs to be looked into. Then our famous mean arterial pressure. Okay, so this is one of the macrocirculatory targets we all talk about that is important. But when we talk about this, this is also, this is the most important thing for organ perfusion. This is the number which is going to perfuse your kidneys, your liver, or any of the visceral organs, your brain, everything. Okay, but this has to be interpreted in the context of CVP. That's why I said CVP is very important, because your organ perfusion pressure is equal to MAP minus the CVP. Suppose if your CVP is very high, the organs are not going to be perfused very well. So that's why I say the CVP is very important. That is the checkpoint, that is the bottleneck, okay, in most of the instances in critical care. So though MAP may be the king, the queen is actually the CVP. So then moving on to pulse pressure. That's the difference between the systolic pressure and the diastolic pressure. Many times we don't, give importance to all these things. We just brush it aside as blood pressure, or we just say blood pressure. So it's systolic, diastolic, mean arterial pressure, and then look at the pulse pressure. Especially it is useful in children like dengue. You can just see here. Yeah, so the pulse pressure is very narrow, okay? After fluid therapy, the pulse pressure is becoming wider. Okay, so we need to give importance to pulse pressure as well. So perfusion pressure, this is what I was talking about, organ perfusion pressure and coronary perfusion pressure. Organ perfusion pressure, like I already said, it is MAP minus the CVP. Okay, so here if you look at the MAP is 50 and the CVP is 18. So it is a very, very pathetic organ perfusion pressure that we have got. Okay, so how can I improve it? Either I can improve it by improving my blood pressure or by decreasing the CVP. Okay, depending on the context. Okay, but we all know that it is important. We know that the organ perfusion pressure is definitely compromised. Okay, likewise for coronary perfusion pressure, that the surrogate, how we can measure is diastole minus the CVP, that is your 40 minus 18. Again, it's very, very low, the coronary perfusion pressure. Okay, so we need to, this, if I see this in a cardiac ICU, especially, I will probably predict an impending cardiac arrest, anytime soon. So that's the kind of importance we need to give to this diastoles and the CVPs. Right. So apart from the four or five things that I've already talked about in blood pressure, these arterial waveforms can be used for in other situations like in ECMO. Say in a VA ECMO, this is a patient on say day 0, and then subsequent day, the first trace you can see there's almost a flat trace. You can see that that's improving to some pulsatility is there, 36 by 29. You can see on subsequent days 50 by 37. This says that the cardiac function is slowly improving. Okay. So that's another usefulness. And during CPR, as you are doing a CPR, if you have an arterial trace and if you can maintain the current diastolic blood pressure above 20, that is something good for the child because you're perfusing the coronaries very well. So arterial waveforms are very, very useful in CPR, and you can check your adequacy of your compressions. So moving on to the QUAIN, the CVP. So we all know CVP, what it means is the pressure of blood in the thoracic vena cava near the right atrium. We measure it using a catheter, which is with the tip in SVC. Traditionally, we all thought, what is CVP? We all thought CVP is equal to fluids, right? Almost all of us will have that thought process. If CVP is low, we can give fluids. If CVP is high, we cannot give fluids. So that's no more the concept, and CVP is not very good at predicting the volume status of the patient, nor in assessing the responsiveness of a fluid challenge, okay? So having said that, many trials have proved that it's not really useful for volume status or volume responsiveness. Does it mean that we should stop checking CVPs? No, not really, because we already talked about, we are talking about organ perfusion pressure, we are talking about coronary perfusion, so it is very helpful that way. And there are a few other things. So we will definitely measure CVP. Is it useful for assessing preload status or fluid responsiveness? No, in most instances. Exceptionally, extremes of values may give some clues. Can CVP changes during volume administration assess fluid responsiveness? Yes, only if interpreted together with a cardiac output, that is if you can measure it, okay? So if I give volume CVP goes from 2 to 4, it doesn't mean much, okay? You know that CVP went from 2 to 4, and that's all is the information that you have, okay? Does CVP reflect RV function? Yes, a double S here, okay? If I have a healthy heart, unless my RV struggles, my CVP will be kept low. So if I give fluids and if my CVP goes up, meaning significantly goes up, then it means my RV is probably not coping and please stop fluids. That's what it means, rather than the child being responsive to fluids, okay? So can the next thing is, can CVP help to improve organ perfusion pressure? We talked about it already, a definite yes. So the recommendations are, fluid loading should not be started solely based upon a low CVP. Again, an isolated CVP measurement is of very, very limited value. You can look at the trends and will definitely give you some ideas, especially regarding right heart function. And abrupt elevation in CVP after a fluid challenge. Say I gave a 10 ml per kg fluid. The blood pressure went from say 40 mean to 42 mean, but the CVP went from say 7 to 16. It means stop, enough. So the advantage that we have gotten is very less compared to the disadvantage that we have got. So do not use it. Okay, so that's about CVP, and information from numbers we saw so far, and from the waveform analysis, it's again a separate talk altogether. Multiple things can be found out from the waveform morphology, like atrial flutter, SVTs, junctional rhythm. Just for an example, here you can see these are tall CVP waves, okay, very huge numbers, and these are the Cannon waves of severe tricuspid regurgitation. So in a patient in a cardiac ICU, we can identify some underlying pathology like tricuspid regurgitation, pulmonary hypertensive crisis by just looking at the morphology of the CVP trace. Okay, so we have spoken about arterial blood pressures and central venous pressures. Now we'll talk about central venous saturations. That is the, so if you place a catheter in the SVC, which is the lower third of the SVC and the RA junction, so you sample it from bloods from there and you look at the saturations of that is your central venous saturations. Normally it's about 25 to 30% less than the arterial saturations. What does it mean if it is low? If it is low, it means the extraction is more, meaning probably the child is in shock, okay? But what if it is high? It means either the patient is too sick that the tissues are not extracting anything at all, or it may mean that there is intracardiac shunt. Suppose if there is a left to right shunt, okay, you are falsely, spuriously, you may get a high venous saturations. Again, venous saturations has lot of fallacies, so please use the trends rather than an absolute number. So venous saturations, I would use it, but you should ensure the tip is in the right place. It should be a neckline, tip should be appropriately placed, and I will follow trends, and I will take it with a pinch of salt if there is an intracardiac shunting. Right, so the recommendations are, so do measure SEVO2 in unstable patients not responding to the initial treatment. In isolation, it's not an adequate marker of cardiac output. Do not target hemodynamic therapy solely based on SEVO2. Somebody's SEVO2 is only 50, but they are walking, talking, playing around with all other markers of perfusion being normal. You don't really have to chase that. We can just accept it. So next comes fluid responsiveness. So what is fluid responsiveness? A rise in cardiac output as a result of volume resuscitation. That's called fluid responsiveness. Unfortunately, we do not have simple, clear, proven methods. There are many tests like IVC collapsibility, pulse pressure variation, stroke volume variation, but all of this have really not been proven to be very, very useful in children. Does it mean that you should not use it at all? No, I'm not meaning that. See, you can use it, but you should know what are its advantages, what are its limitations. Okay, and then you can use it and play it to your strength. So the only fluid responsiveness test which has been proven to be useful in children is the respiratory variation in aortic blood flow peak velocity, which can be measured using an esophageal probe, or you can have, Doppler methods basically. So other tests like passive leg raising, pressing on the liver, and checking for fluid responsiveness, all that is not good enough or has not been proven to be useful in children. So what can you do it in real time? Okay, so administer a small volume of fluid over a short period while you track changes in cardiac output, blood pressure, and CVP. If there is a good response, then you can consider additional fluid bolus and use only small volume boluses like 5 to 10 ml per kg rather than like 20, 30 ml per kg, because the fluids, once you give in, you cannot take it back, and fluids can cause a lot of harm. So from the arterial waveform analysis, many parameters like pulse pressure variation, stroke volume variation, stroke volume, cardiac output, all this can be determined, and this arterial waveform analysis is one of the ways by which cardiac output is measured. Okay, that's just for completion I mentioned. So moving on to echocardiography and ultrasonography, that's called point of care ultrasound. It's non-invasive, easily available, real-time assessment, serial assessment. It can assess your response to therapy. So it's really, really useful, really, really beautiful to work on. All you need is to just take the probe and put it on the patient and start learning. So we can assess preload status and cardiac output. That you can do by measuring VTI across the aortic valve. You can check cardiac function, RV, LV, systolic, diastolic. You can see if there are anatomical defects, whether there are pulmonary hypertension. You can use it for diagnosing a cardiac tamponade, and you can also look at features of cardiac fluid intolerance. Okay, so cardiac ultrasound is very useful in identifying the pathophysiology of underlying shock. So, but the limitation is you cannot do it continuously. You cannot be keeping a probe continuously. So you need to measure it intermittently. Okay, that's the most important thing. So look at, okay, this is not working. So you can see a dilated heart here. Okay, right? So that you can see with your focus. These are B lines of wet lungs. So dilated IVC. With this, probably if this patient is in shock, this is probably some cardiogenic shock, okay? And the heart function is poor. So it gives a lot of information, very, very useful information, all right? So focus is definitely an adjunct to gain additional information rather than a primary tool. Use serial assessments to assess response to therapy in patients with hemodynamic instability. A word on cardiac output monitoring. So cardiac output, see, so far whatever we saw are all, these things like, cardiac output is equal to stroke volume into heart rate, and we are looking at different components which contribute to the stroke volume. So far we have not talked about directly whether you can measure stroke volume or cardiac output, okay? So there are various, methods, and the most commonly and proven to be useful in children are transthoracic ultrasound, that's your echocardiogram, and transpulmonary dilution. Okay, this is your echo and this is your VTI, which you can identify with, which you can measure with your echo, and from there you can derive cardiac output. And the other thing is transpulmonary dilution. This is the most reliable clinical method to measure cardiac output. This is based on the principle of basically, thermodilution, but there are a lot of practical challenges like resources, expertise. It's very invasive and it's not suited for emergency resuscitation. So generally we have not been using it. The two methods which are available in children are the PICO and the transpulmonary ultrasound dilution. I think we should know the names, and both are not in frequent use in the ICU. It's an intermittent measurement technique, and vascular access is difficult at times. So, do you really need to measure cardiac output in children? Like, see, I have clinical signs to measure, I have arterial blood pressure, I have so many components in it, I have the waveforms, I have CVP, I have echo. Do I still need to go and measure cardiac output in every patient? Not really. Use in refractory patients, where you are struggling to, get the patient better. Okay, so use it in, and that too you use ultrasound or Doppler-based methods, which is your echo-like stuff. And if you really need it, then you can use thermodilution, and measuring cardiac output using pulmonary arterial catheters are not recommended in children, unlike in adults. And even in adults, most times we are not using. There are other less non-invasive methods based on bioimpedance, pulse contour, and Doppler. These are not really fully validated in children. This is ICON. This is based on bioimpedance and electrical cardiometry. We do use it in our unit. It is useful, but again, you have to use trends rather than absolute values. This is a flow track system. This is another way of measuring arterial blood pressures and cardiac output. Pulmonary artery catheter, as I told you already, is not recommended in children. Lactate. Lactate is something which is easily measurable at the bedside. You can get it immediately, and it can predict outcomes. If somebody's lactate is not clearing, it may mean the child is going to do very badly. And it can be a trigger for the need to intensify therapy. You do blood gas, like I showed initially, the lactate is 9. That actually triggered the entire cardiothoracic surgical team, cardiology team to come from home on a Sunday night, and that child got operated. It was only that number, lactate of 9. Okay, that means the child's perfusion is compromised. So it can serve as a trigger to intensify therapy. So you can measure, but measure it from a reliable site like central venous or arterial catheter. Can you use capillary? Can you use peripheral venous blood gas lactates? Okay, can you use it? If your tourniquet time is less than 60 seconds, you can use it. Otherwise, preferably not. If you think it's not correlating, please take a reliable, like a free-flowing arterial sample, confirm your lactates, and then proceed. Again, trends are more important, and one thing I would like to stress upon is elevated lactate in many instances reflect other mechanisms such as catecholamine excess. Patients comes with asthma, and then we give back-to-back nebulizations, give beta agonists, and then the next gas will show a lactate of 6 and 7. Doesn't mean that the child is perfusing poorly. So many times it's iatrogenic rather than actual pathology that is causing. A word on NIRS. NIRS is basically, you use near-infrared spectroscopy. You use probes like, how you measure saturation. You measure regional saturation with the use of probes. Commonly used is cerebral. Sometimes people use even renal. Whether we do not have clear cutoffs to say this is abnormal. Usually it is in the range of about 70%, 60-70% in healthy patients. In patients with cyanotic heart disease, it's in the range of 46 to 57%. So do I need to use it? Trends again may be useful. Routine use is definitely not recommended. It may be used in perioperative period after surgery for congenital heart diseases. Okay, right. So a word on microcirculation. See, whatever parameters we saw are all macrocirculatory parameters, all blood pressure, CVP, lactate, so all these things, but the main microcirculatory parameters are like capillary refill. They may be, we don't, whatever we normalize, we can address only the macrocirculatory parameters. The microcirculation is what the body decides for its own self, okay? So there is not much of ways to assess microcirculatory disturbances. One thing which we use regularly is the veno-arterial PCO2 gap. So you do venous blood gas, you do arterial blood gas, look at the difference. In healthy, you and me, the normal value is about 6. If it is wide, it usually means a low cardiac output state, okay? But you don't have to be, again, chasing that number provided everything else is normal. So things like CFT, temperature, lactate, all that do not adequately reflect the microcirculation. So do not use it to guide resuscitation, but you can just look at it and track it. So, in essence, the ones lighted in green are something I'm going to routinely use. Clinical signs, that's the first, yes, yes, yes. Next, arterial blood pressure, if possible, invasive. CVP, a double S. And POCUS, echo, definitely yes. Lactate and mixed central venous saturations, yes. So, these are all things I would definitely use to monitor my patient. And fluid responsiveness, NIRS, VaCO2 gap, yes, I may use depending on the circumstances. A cardiac output measurement only in really patients who are very, very sick, refractory to treatment, your inotrope requirements are escalating. Those are the patients I would use. So, irrespective of the tool use, clinical context and assessment are important. I'm just stressing that again and again. So, because that is the first thing. Because I get calls in the middle of the night from my fellows, ma'am, stroke volume variation is this much. Hello, please tell me what's the clinical finding first. So, people, especially the younger generation, gets hooked on to those numbers which are displayed in the monitors in the bedside rather than clinical assessment. Because I tell my patients, fellows always, namaskaram, right? A namaskaram at the patient's feet is the first thing you should do because that gives a lot of information like CFT, pulse volume, temperature. That's the first thing you should do before looking at everything else. So clinical assessment is important, and be aware of how to interpret the tool you use and its limitations. See, every tool has its limitations. So it's not like one is better over the other. As long as you know this is the strengths of this machine, this is the weakness of this machine, and I will interpret it like this in this particular context. Any tool is a good tool, any tool is a bad tool. So, and repeated assessments are crucial. Monitoring trends in anything is vital rather than a snapshot evaluation. Hemodynamic monitoring will always remain a puzzle where pieces are need to be put together. Thank you very much. Thank you again for the opportunity.
Hello. I think there must be many questions from the audience. I may allow 3 or 4 questions from them. Okay. Anyone? No question?
Yes, yes.
Good afternoon, ma'am. Whenever we do resuscitate, we look at the arterial blood pressures first, but there's something called that early goal-directed therapy that we follow, and the table that is there, the flow chart which is there, it first targets the CVP and then the arterial pressure, and then it comes to lactate or central venous saturation. Okay. Why is so?
So early goal-directed therapy was started in the early 2000s. Okay, it was a study which was done, and at that time things were very different, and they targeted some numbers. 25 years almost have gone past, and you really don't have to chase the CVP. There are many studies to say don't chase CVP. Okay, as I said, CVP, use it as the downstream pressure and a function of RV rather than using it as a initial therapeutic target.
The study was in JIPMER in 16 and 18 or around 20 was basing on that same flow chart, and
I need to look at that study, but this is the message basically. Okay, you don't really need to, because if you chase that you will not head anywhere because you'll go on giving fluids or because CVP there are I haven't put up that there are do not target any CVP number. That is the first message.
Thank you, Dr. Priya. Wonderful talk.
Thank you, sir.
I just want to ask you about your experience with the non-invasive cardiac monitoring, cardiac output monitoring. I mean, I believe your unit is very regularly using different equipments at different times, like you used, I know Sujitra told me, ASCON and, other things.
Yeah.
So how reliable are they?
Sir, there are instances where it has helped, there are instances where it it doesn't correlate with the actual, clinical scenario that we are seeing in. So what we do is, we don't put it regularly. We have used ASCOM in the past, now what we are using is the ICON. So it's not like every patient with shock, gets that, probe, all those leads. We don't do it. Because the more the number of parameters that you have to, the puzzle becomes bigger basically when you have so many. So in difficult cases, you are on a lot of inotropes, then we put it. And there are some measurements like cardiac output and stroke index which are reasonable. Measurements like SVR, SVRI, all that is, you are inputting a data like MAP, okay, and it derives that calculation. There it becomes a little bit, sometimes it is not really correlating with that. So what we do, suppose the stroke volume, SVRI is coming low and we are going up on the pressors, you see the other markers after therapy. If lactates are improving, your cardiac function is improving, CFT is better, then probably you are in the right track. Otherwise, we ignore that. We need to repeatedly enter the right numbers because some are actual measured variables, some are derived variables.
Actually, what is, I have experienced, I don't have any non-invasive cardiac output monitor in my unit. We have multiple demos by different companies. But ultimately you realize that, all these have been validated in the adult cardiac, where they undergo bypass and everything is all right.
True.
But in the pediatric ICU, I'm not talking about cardiac ICU, I'm talking about the general pediatric ICU, we have very different hemodynamics and the physiologies are very different. So these have not been validated, like especially in septic shock and all, some kid is, one kid is vasodilated, the other kid is vasoconstricted. So the reliability factor is not there.
So like, we have a septic shock, we have an arterial blood pressure where you have a wide pulse pressure and your SVRI in the icon, say for example, shows high. Okay, it's not adding up. So at that time, we need to titrate therapy based on other information that we, get. So it is not like I would suggest that please do it. But if you are buying anything, you just need to kind of see what works in that particular machine and what doesn't work.
So the bottom line is keep the patient in front of you and then interpret the numbers. If the numbers are not fitting with the clinical context, then hold on.
Yes, sir, absolutely.
Right. Thank you so much.
Thank you so much.
Thank you, Dr. Priya.
Thank you.
You have nicely covered this vast subject in this short time and wonderfully explained. It is very much informative to all of us. Thank you once again.
Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you, both of you. So I would like to request Professor Shopna Chakraborty to hand over the memento to Dr. Priya and Dr. Priya to hand over the memento to Professor Chakraborty. Thank you once again.